my name is Bruce Wainman. I'm the director of the education program in anatomy at McMaster University, and this is a lecture on intersex. And this is hermaphroditus. This person is the son and daughter of Hermes and Aphrodite. If you look, you can see that this person has the typical fat pattern deposition that we expect in females. We can see there is a breast and also the curvature of the buttocks because of subcutaneous fat. But hermaphroditus is also in possession of a penis. So how did that occur? Well, if you believe the myth, Salmachus, the nymph, in fact, attacked the young hermaphroditus, and what happened was she was rebuffed, and she complained to the gods, and she said she'd like to be part of hermaphroditus, and so what happened was, in fact, they were combined. And so hermaphroditus, who started out as a boy, in fact was combined with Salmachus, and we have hermaphroditus here as the hermaphrodite. So this does bring up a number of different issues. I think one of them is to start thinking about sex and what it actually means. So there's different types of sex. We can think of genetic sex, and that would be with two X chromosomes, you're a female, and with an X and a Y chromosome, you're a male. There's also what we could call phenotypic sex, and that's the appearance that someone takes on. So I think many of us have in our mind something that's particularly female looking, and then we also have the appearance of males. So that's phenotype. There's also going to be gonadal sex. The gonadal sex would typically be, if we had testis, that would be a male, and if we had ovaries, that would be a female. And then there's also the behavioral or psychological aspect of this, and that's how the person self-identifies. That's one way of saying their gender identity. So if they feel like they are male, then they're male, and if they feel like they're female, then they're female. In the case where the assigned sex, that is to say that what we call the person is different than their gender identity, then typically we would refer to those people as being transsexual. You'll notice that in this discussion of the different types of sex, I haven't mentioned what people are attracted to. So whether they are interested in females or males, that's a whole other area to think about. Most of what I'm doing today is going to be talking about the developmental biology. And so to do that, we have to really start very early in the development of the embryo. And I've made a picture here. It's obviously not the greatest picture you're ever likely to see, but I think that it's pretty indicative of what's going on. So what is going on at the 5th week? Well, we start early in development with something called a mesonephric kidney. Now, that kidney does not go on to be anything really important. It, in fact, completely involutes, but it does have a mesonephric duct that drains it. And that mesonephric duct is sometimes called a Wolffian duct, and so I might use those two words interchangeably. The other thing we have is a paramesonephric duct, or a Mullerian duct. Now that paramesonephros is next to the mesonephros, and that's how it got its name. We also have what we would call an indifferent gonad. And indifferent doesn't mean, it doesn't really know what it wants to do or doesn't care. What it means is it hasn't gone down one or another developmental path. So it's a potential ovary, and most of what will become the ovary is in fact on the outside. So if that develops, we get an ovary. And if we look in the stroma on the inside, that's typically what's going to develop into a testis. And so it's indifferent in the sense that it hasn't decided what it's likely going to end up to be. Now this terminates, particularly those ducts terminate in a cloaca, and that's going to leak out of a urogenital sinus. And there is our cloaca. Now, at this point, it hasn't really differentiated to the degree where we could say, okay, here's exactly where the rectum is and the bladder is. Essentially, the bladder will come from the front and the rectum will be in the back, but that happens a little bit later. We're mostly interested, in fact, in the ductwork and in that indifferent gonad. So those gonads are not going to stay indifferent for long. And the reason for that is going to be that there's a big difference between having two X chromosomes shown on the left or having an X chromosome and a Y chromosome. And if you have an active Y chromosome, it's going to start to lead to differentiation of that genital tract after about 6 weeks. And it's going to change urogenital development. And I'm not going to talk quite so much about the uro part, which is the kidneys and the bladder and that sort of thing, but these are all going to happen concurrently. So then, having two X chromosomes, or an X and a Y chromosome, can profoundly affect urogenital development. So what are we going to end up with? Well, it's hard to know. If we look at this very early embryo, so it's after about 6 weeks, we can see that we've developed a bit more of a kidney. This is a metanephric kidney, and that's the one we'll end up with later on as adults. We've got our mesonephric kidney, and you can see that the mesonephric kidney is in fact breaking down at this case. We've got our ductwork forming over here. We've got our cloaca right here and a urogenital sinus. Interesting, to me at least, is that we really are not having urine or anything going out through here. Very early in development, we're going to have leakage through here, which is the urachus, and that's going to be important for getting rid of urine and that sort of thing. So if we have chromosomes that are X and Y, we often end up with what we would say is the male phenotype. If we have two X's, then we're going to end up with the female phenotype. But in reality, if you remember how I discussed the different types of sex, in fact, we sort of end up with something in between many times. And the reason for that is that there's so many definitions of sex, then perhaps we're going to end up with something intermediate. So if we just look at that XY phenotype, it's fairly interesting. What typically will happen is that we're going to start with this Y chromosome creating all sorts of havoc, if you will. So on the Y chromosome, you notice that it was very tiny. Well, one thing that it does have is something called the SRY gene, and this is the sex-determining region of the Y. And so the sex-determining region of the Y is going to give you something called testis-determining factor, or TDF. TDF is absolutely essential for generating the XY phenotype. And what it does is twofold. One thing is that it begins to stimulate Sertoli cells in the gonad. And the reason that that's important is that those Sertoli cells make a hormone called anti-Mullerian hormone, or AMH. And when that is made, we're going to have the Mullerian ducts regress. That is to say that the Mullerian ducts will go away. Well, why is that important? Well, it's important because those paramesonephric ducts, or Mullerian ducts, are typically going to form the female genital tract. And so with an XY phenotype, you actively make a hormone that inhibits the development of the female reproductive tract. But you don't just have to inhibit the female reproductive tract, you have to make a male reproductive tract. And how does that happen? Well, TDF also will affect the Leydig cells in the gonad. And those Leydig cells, once they're stimulated, will begin to make testosterone and other androgens. And why that's important is it's going to stimulate the mesonephric ducts to begin to develop in the male. And the mesonephros, or the mesonephric ducts, are going to give us a lot of the male reproductive tract. And the testosterone, of course, will also cause development of secondary sexual characteristics, such as the penis and things like that. And so, essentially, on that little tiny Y chromosome, there's not a lot. There's not a lot of genes on there. It's very simple. And in fact, it's a bit of a problem, right? Because females have two X chromosomes. So if they have one bad copy of a gene, then maybe the other X chromosome will have a good copy of that gene. But males don't have that. They only have one X for, in fact, most of the useful genes are on there. And then on the Y chromosome, we have only a few genes, but one of them is the SRY gene. And it's important for the development of both the mesonephric ducts and the inhibition of the Mullerian ducts. So with those two occurrences, we're likely to end up with the male phenotype, or the classic male phenotype we can see here in this boy. So I've made this cartoon of the XY phenotype development, and as you recall, we're going to make something called anti-Mullerian hormone, and so that will cause the Mullerian duct to go away. So we're losing our paramesonephros. The other thing that's going to occur is that we're going to start making a gonad. And in this case, we're making the male gonad or testicle. And that will begin to descend down lower into the pelvic cavity. And of course, at the very same time, as you probably realized, I showed the loss then of the mesonephric kidney. On the right-hand side, nothing changed. And that's actually quite possible if there is a person who is a mosaic and they don't have every single cell is not XY. Perhaps on that side they have two X chromosomes. You could end up with this configuration where in fact the Mullerian duct system doesn't really go away. At any rate, we are having the situation here where we had anti-Mullerian hormone and we had production of testosterone and other androgens, and that's led to the mesonephric duct draining what will become the testicle. In the XX genotype, we're going to have a slightly different embryology. What will happen in that case is that the outer part of that indifferent gonad develops into an ovary, and of course the Mullerian system, the paramesonephros, is going to occur, and now we are going to end up with that system of development that is more along the female side, because those paramesonephric or Mullerian ducts are going to give us the fallopian tube, and then they're going to fuse to give the uterus and even part of the cervix and vagina. And of course that ovary is also going to move down. Now of course in the female the ovary doesn't move right out into the scrotum. It stays in the pelvis, which is a remarkably smart thing to do, and so it's going to stay within the body cavity. And so that's the difference then between the XY, where we make a testicle and we have the diminution of the Mullerian system, and in the female where we have the Mullerian system continuing to function, and we have an ovary made from the exterior part of that indifferent gonad. One of the things that is interesting is that there is no anti-Wolffian system. There's no anti-Wolffian hormone. And so we'll find there's little tiny remnants of the mesonephric duct system in females, and generally they're not a problem. As I mentioned, the renal and gonadal systems develop together, and so that is why we call it the urogenital system. So I thought you'd like to see some of the embryology. We're just going to follow the XY phenotype. It's fairly similar to the XX phenotype. With the XY, of course, we're going to begin to lose the paramesonephric duct, and with development we also lose that mesonephric kidney. We're going to convert that indifferent gonad into the testy, and of course that testicle or testis is going to descend, and it's going to occur at about the same time as we get the development of our metanephric kidney. So perhaps you missed that, so I'll go back just a little bit. So right off of that mesonephric duct, we're going to have a bud, and the bud reaches out and then forms up our metanephric kidney. I know that seems unbelievable, but in fact it's true. If you had several metanephric buds, you would end up with several kidneys. If you have no metanephric bud on one side, you end up with kidney agenesis. You just don't develop a kidney. And so now we have, in this case, a male gonad and a metanephric kidney. And if you look at that, it really emphasizes something that's very peculiar. We have our gonad up in the abdomen somewhere, and we have our kidney stuck down in the pelvis. Well, what happens is almost unbelievable. The kidney is going to ascend up into its normal position on the posterior body wall, and the gonad, of course, is going to descend with that mesonephric duct following it, which is going to make the vas deferens. And so you can see that they, in fact, pass each other. I wonder if they have something to say as they go past. I just find it amazing that we're going to have the ascent of the kidney, the descent of the gonad. You think they could have agreed and just said, okay, fine, we'll just not bother passing each other. We'll just trade or something like that. But it doesn't work that way. What that means, though, is we end up with some pretty complicated anatomy. If we look at the male, we can see that that is going to be our mesonephric duct bud that gives us our ureter. And there it is going into the bladder. And then just over top of it, we're going to have the gonadal descent, and so we have the vas deferens going over top of the ureter. And so that's how that occurred. It was only because the kidney went upwards and the gonad came downwards that we end up having the ureter being underneath the vas deferens in the male. So sometimes people say that means that we have water under the bridge. It's supposed to help you remember. I suppose the bridge then is the vas and the water is what we have in the ureter. Well, sometimes this doesn't work out quite the way that we think it's going to. What would happen if the Mullerian duct didn't degenerate? Maybe there was a shortage of this Mullerian inhibiting substance, which is also, by the way, called anti-Mullerian hormone or anti-paramesonephric hormone. Oh, there's so many names for it. But at any rate, what if you didn't make enough of it, or if there were no receptors on that person's Mullerian ducts and they still had X and Y chromosome? Well, they would make the gonads, but then the Mullerian duct syndrome might occur. And so what we see is that this situation. So we have a testicle, that's the left testicle, and we have the, there's the seminiferous tubule. I've shown the right seminiferous tubule, but you can also see the left one. And we have a persistent paramesonephric duct. Well, if the paramesonephric duct doesn't go away, then how do those testicles descend into the position that they're supposed to have in the scrotum? So what I'm saying is that these testicles are supposed to end up down here in the scrotum, but we've got a paramesonephric duct that was supposed to regress and didn't, so it hung the testicles up in the abdomen, and so we would have what is called bilateral cryptorchidism, which is just to say that you have two undescended testicles, one on each side. So that does bring up this interesting fact that we have the testes going through the inguinal canal. The descent of the testes into the scrotum does occur through this inguinal canal. And the inguinal canal is essentially like a tube, and it has a deep ring that opens to the abdomen, and then it has a superficial ring that opens up to the scrotum. And the thing that's going to move the testes downward is called the gubernaculum. That stands for little governor. You might have heard in the United States, particularly when someone's running for governor, it's called the gubernatorial race. And in my mind, I'm always imagining two testicles racing. So that's probably not the right thing. It's just a problem with being an anatomist, I suppose. But at any rate, the gubernaculum is the thing that's pulling the testicle down through the deep ring of the inguinal canal, out through the superficial ring of the inguinal canal, and then down into the scrotum. And once that testicle's in the scrotum, then the gubernaculum has done its job. And I've shown a picture here. Essentially what it's showing is that here we have the testicle, and right here we have the vas deferens, and there's the seminiferous tubules. And this long blue structure right here is the gubernaculum. Well, that must mean that this is the inner ring of the inguinal canal. And then we have our superficial ring of the inguinal canal. And so through the deep, out through the superficial, down into the scrotum, which is forming right here. And here's the beginnings of what will become the penis. So if we follow this, we'll see that in fact the testicle here is being pulled down, And as it does it in fact pulls in some peritoneum. Remember, the abdomen and pelvis is completely lined with peritoneum. So as you pull the testicle down, in fact pulls in a little fold of peritoneum. And there's the testicle continuing to descend. This is really only happening very late in the 3rd trimester of development for the fetus, until finally what we end up is we've got a testicle, a very short gubernaculum, and it's all within a scrotum, but right here we've pulled in a bit of peritoneum through the inguinal canal. And so that has to seal off at some point, otherwise we're going to have bowel going to sneak down there and get into the scrotum, and that's definitely not something we want. Incidentally, this little space right here is going to become the scrotal cavity, and we'll talk more about that later, but this inguinal canal has to seal off. So the inguinal canal then is key, and where does it sit? I found this rather useful picture, and you can see we've got our deep ring of the inguinal canal, and then our superficial ring of the inguinal canal. There, of course, is our obturator foramen. We're not really thinking about that, but you do have to wonder what that big round white thing is in the middle. And so essentially the testicles then are going to come through the inguinal canal and then descend down into the scrotum. I have noticed there's something here for number 2. That's the pubic symphysis, and you might be wondering what this long white line is. Well, this person's been catheterized. So that's going to be the catheter that's going up into their bladder. So that's not something you really have to think about. And so if you look and you're trying to orient yourself on this is online, so suppose if you're at home, you can dig away here. This is your anterior superior iliac spine, so you can palpate that. It's the one that's usually sitting just underneath your belt, and you can feel it poking outwards. And then as you go inferiorly and medially, so downwards and towards the middle, you can palpate your own pubic symphysis. And so about halfway down between the anterior superior iliac spine and the pubic symphysis is going to be the inguinal canal, the deep ring of the inguinal canal. And then right almost at the pubic symphysis, but just above it, is going to be the superficial ring of the inguinal canal. And that is where the testes come down. So I made a little animation to help with that. We can see that we have our testes right here, or a testis, if you like. It's going to have a vas deferens coming to it. Remember, that's going to be mesonephric duct that's left over. We've got our gubernaculum here that's going to be doing the pulling. We've got the inguinal canal, which is just this space. And we have a deep ring of the inguinal canal, which opens to the abdomen, and the superficial ring that's opening to the scrotum. This is what we would call the genital tubercle. The genital tubercle can develop into a penis in males or into a clitoris in females. At this point, it's pretty hard to know which way it's going to go. And then we have what we call a labioscrotal swelling. So in the female, it'll become labia, and in the males, it'll typically seal up and become a scrotum. So what'll happen then is that this peritoneum that we've shown right here has got transversalis fascia, and you might remember that from earlier lectures on the abdominal wall. But just think about the peritoneum, that light, shiny material that we have all through the interior of the abdomen. And what's going to happen then is, as this testicle is pulled, it's really connected pretty closely to that transversalis fascia with the peritoneum on top, and so it's going to start descending with the testicle. So you can see it beginning to descend, and it's pulling in the peritoneal lining. And so what we end up with then is going to be the testicle and the scrotum, and a scrotal cavity. So let's have a look at that in more detail, because there are things that can go wrong. So I made this picture to help with that. There's our peritoneal cavity, as I talked about, lined with peritoneum. We've got our gap that was made by the inguinal canal, and in this case, because we pulled down the peritoneum, we call that the processus vaginalis. And I know that's introducing another word, and it seems unfair. In fact, it's introducing two words, but it will help you in the long run. So this is the inguinal canal. It's been obliterated, and but because it was lined with peritoneum, as it was, we're going to call it the obliterated processus vaginalis. Then we have our pubic symphysis right in the middle, of course. And then there's our vas deferens that goes all the way down to the seminiferous tubules. And here is our scrotal cavity that is, in fact, a potential space. Normally, of course, it's not really distended like that. This one happens to be full of fluid. And then we've got our visceral layer of the tunica vaginalis, and so that's just pretty much lost peritoneum. And then we've got our parietal layer. Remember viscera, because it's on the testicle, which is the organ. Parietal means that it's not on the organ. And then we have this little space here, the scrotal cavity. Of course, behind it we have the testi, and then we have our epididymis with the seminiferous tubules in it. Now, the path of the sperm is going to be essentially testis, epididymis, vas deferens, and then it's got to go back out through the penis here. But you can see that the anatomy is pretty fascinating, and it does leave us with this potential space. So normally this is sealed up, but what happens if you happen to have, for example, poor drainage from the testis, or perhaps a blood vessel in the testicle is ruptured? Remember, the testicles are in a pretty unfortunate position, sort of leading out in front of the body, and so they do get damaged. And if they do, what happens is you begin to build up lots of fluid in that scrotal cavity. Now, if it's just regular fluid, if it's just serum, then we refer to it as a hydrocele. If it happens to be full of blood, then we would call it a hematocele. So that is the situation that we get. And the reason we get it is because we've got a scrotal cavity that was formed from the lost peritoneal cavity. And so there's an example of a hydrocele. You can see a sort of normal left testicle here, but this one is badly swollen up. And so what's happened is that that scrotal cavity is filled, probably in this case with fluid, but it's hard to know because we haven't removed the fluid from the scrotal cavity. It could be blood. Okay, the interesting thing about those testicles is sometimes they don't really descend very well, and you might have to do something called an orchidopexy. Pexy is just a procedure where you tie off an organ and put it somewhere, essentially. And orchido refers to the testicle. So orchidectomy is removal of a testicle. Orchidopexy is tying a testicle somewhere. And of course, cryptorchidism. Cryptos is hidden, and orchid is testicle, so that's hidden testicle. Really, it's synonymous for the most part with undescended testicle. So let's have a look. About 4% of male newborns have an undescended testis. This is much higher in premature babies because the inguinal part of the testicular descent is a third trimester occurrence. So the earlier you're born, the less likely the testicle is going to be in the scrotum. And so typically people are just going to watch and wait to see what happens. About 75% of the time, that testicle is going to descend all by itself, and there's really nothing to worry about. The gubernaculum does its job, and it's going to pull the testicle down into the scrotum. If the testicle doesn't descend, then we can do a pexy procedure on that testicle and actually pull it down into the scrotum. And I thought I would show you that because it does actually help you understand the anatomy to see this surgical procedure. By the way, you can't really leave the testicle up in the abdomen. We're quite afraid, in fact, that that testicle might become cancerous, developing in an inappropriate spot. So sometimes they'll try to get it to descend, or they'll just remove it. Males do just fine with only one testicle. So here's the procedure. I wish I had better pictures, but what can I say? I do not. So if we look in that inguinal canal, and in this case they've found a testicle in the inguinal canal, which is not good, then you want to pull that testicle down from the area that it's in the inguinal canal, down into the scrotum, which is right here. So it actually takes two incisions, an abdominal incision and a scrotal incision. And so here's the abdominal incision. and they've cut into the inguinal canal, and they found the testicle. There's the gubernaculum that didn't do its job, so they're just going to cut that out of there. And so what'll happen is they will open up the abdominal incision and take out the testicle. Now, the testicle is kind of fascinating in that, remember, it started way up in the posterior body wall. Well, what happens is it brought its blood supply with it. So this is the artery and the vein, in fact, the nerve of the testicle. So you separate those, and you loosen up a little bit of the artery and the vein and the vas deferens from the body wall. And then what they do, which is fascinating at least to me, is that they tie on some suture material, and then they push that suture material all the way down to the base of the scrotum, which is shown right here. And these clamps push the suture material right to the base of the scrotum. And then all you have to do is grab the ends of that suture material and pull the testicle all the way down and put it in place in the scrotum. When you get it in there, you seal off the bottom of the inguinal canal, so the superficial ring of the inguinal canal, and of course you suture up the testicular incision and the abdominal incision, and now the testicle is where it should be, and hopefully that blood supply and the vas deferens haven't been damaged. And so that's an orchidopexy, and essentially what they're doing is pushing the testicle through the inguinal canal because the gubernaculum didn't do it. I guess that leaves us with the question is, why do the male gonads, the testicles, end up outside of the body? It seems like a terrible place to put them. Well, the reason is because sperm like it that way. Spermatozoa really need to develop at temperatures that are 2 to 3 degrees Celsius below body temperature. And the only way to do that is to put the testicles outside of the body. So to maintain that temperature, what's going to happen is essentially the testicles will be taken in closer to the body to warm up, and then to cool them down, they're going to be allowed to go away from the abdomen. And so the movement upwards is going to be accomplished with a striated muscle called the cremaster muscle, which is an extension of the internal oblique muscle that comes down the inguinal canal. And the dartos muscle is not going to pull the testicles up, but in fact going to compress them. And so the movement of those two muscles together is going to make the scrotum smaller and closer to the abdomen, where it's going to warm them up. And of course, if you have to cool them down, you just relax the cremaster, relax the dartos, and then the testicles get away from the body, and then they should cool down. Of course, that made a lot more sense when we didn't wear underwear. It occurs to me that cooling is not going to work nearly as effectively when you have underwear on and pants, because in fact the testes can't really move as much as you would expect in the situation where they were free to roam around. At any rate, both of these are going to be activated. So in cooling, they're going to be both relaxed, and in warming, they're going to both be stimulated, and that should cause that temperature change that we're looking for. There's another occurrence that's pretty interesting. I refer to this as a testicular thermostat, but there's several things going on. So I've got a picture right here, and there obviously is our testicle. It's got many, many layers, and of course that little space right there, by the way, is the scrotal cavity we were talking about. At any rate, we have our cremaster. There it is. This is going around the outside of the inguinal canal, part of the wall, and it is, like I say, part of the internal oblique that sort of spirals down. It'll move up and down, move the testicle up and down. It's striated, so it's actually under control. The dartos muscle is a smooth muscle. Now, the dartos muscle is smooth, and so it's not under our control, and so it's got a number of reflexes controlling it. Okay, so cremaster striated, under control. Dartos, smooth muscle, not under our control, but has reflexes. So those are going to work to cool and warm the testes. But there's another mechanism, and here it is. This is the pampiniform plexus. And you will notice that the artery coming here, the gonadal artery coming down, is surrounded by a venous plexus. So it's surrounded by a bunch of veins. Well, why is that the case? Well, it's fascinating. This is warm arterial blood coming down. Now, this blood has been in the testicle and is now returning into the body. Well, once it was out in the scrotum wandering around, it was cooling down. And so this pampiniform plexus is going to cool the incoming warm blood. Warm blood comes in, cool venous blood surrounds it and cools it, so that we are going to get a countercurrent heat exchange, and that will allow us to have cooler blood going to the testicle, and thus that is going to allow for that 2 to 3 degree temperature change. So we have a number of mechanisms there to keep the testicles at the right temperature. The presence of cool testicles is going to be costly, though. What it means in humans is that the scrotum and the testicles are out and exposed to possible damage at many times. And of course, that occurs in sporting events, for example, even just in bad trips and falls. People will in fact rupture a testicle, and you'll end up with those hematoceles that I was talking about. But we're lucky in the sense that at least you only need one testicle to be functional and produce sperm. The other big problem is that males are going to have inguinal hernias, and you can see this picture that I've shown on the right-hand side. What happens is males will have what we call inguinal hernias, and there's about 25 hernias in males for every one in females. And in fact, we repair 100,000 hernias a year in Canada, so this is a big deal. So what happens in a hernia? Well, remember that the inguinal canal had to stay open in males so that the gonad, the testis, could descend. Well, that makes a weak point in the abdominal wall. And so later on in life, this weak point can allow a chunk of bowel, in this case here is that bowel or intestine, pushing out. And so it's come through the fascia of the abdomen and pushed out, and then it bumped into the inguinal canal and is beginning to go down into the scrotum. So this is a typical type of direct hernia, we call it. Direct because it went directly through the abdominal wall, and then it came into the inguinal canal and begins its descent. By the way, surgical repair means you push the intestine back and you seal off that area of fascia that's weak, usually with a mesh. So this direct hernia, directly through the abdominal wall, and this is the type that people tend to get later on in life. And so we will sometimes call this an acquired hernia, or that is to really get it completely distinct from what we would call an indirect hernia. That's the one that we will see in newborns or very young children that have testis. And the reason for that indirect hernia is that it goes through the inguinal canal. So you can imagine very early in development that inguinal canal hasn't closed off, so that processus vaginalis hasn't disappeared. And so what happens is a loop of bowel can get through the inguinal canal. Now we call that indirect because it didn't actually go directly through the abdominal wall, did it? It actually found the inguinal canal and snuck through there. Those are relatively rare, but we look for them on newborn exam and things like that. And this is an example of a very large and fairly unfortunate looking indirect hernia. And so this very distended scrotum here, you can see their anterior superior iliac spine, has a very large loop of bowel that's gone through the abdominal wall, found the inguinal canal, and then continued downwards. You can't really even see the tip of the penis here. I only really know it's there because you can see this rather large catheter. It's a Foley catheter that's draining their bladder, and so I hope this person is in for repair. So external genitalia is another thing to think about, and how does it develop? We've talked a lot about the ducts and the descent of the testicles, but how do the external genitalia develop? Well, we have to start early, at the indifferent stage of development at 5 weeks. And so we start with what's called the genital tubercle, and we're going to have labioscrotal swellings on either side of that potential opening, and that's the urogenital or urethral folds. So all of these things are giving you an idea of what they're going to become, right? The genital tubercle can become either the clitoris or the penis or something in between. The labioscrotal swelling that we see on either side, well, it's labioscrotal, right? It can become labia majora, or it can become the scrotum. And then we have the urogenital or urethral folds. Those can become the labia minora and also form part of the urethra. Right down the middle, we have the urogenital sinus that I talked about. That urogenital sinus is open essentially to the bladder a little bit later on in development. At 10 weeks and under the influence of androgens, and it doesn't matter if you have two X chromosomes or an X or a Y, as long as you have androgens, the urethral folds are going to meet and seal up. And so those urethral folds are going to begin to make a typical male-looking urethra. In females, of course, without the androgens, those urethral folds will not seal up. The labioscrotal swellings are going to swell, hence the name, towards each other, and the tip of the genital tubercle is going to begin to take on the appearance then of the glans penis. And in fact, even on ultrasound at some clinics, you can begin to see the development occurring at this point, because the genital tubercle begins to swell up, and that is likely to become a penis. And so there's our genital tubercle. There's our swelling, labioscrotal swellings. You can see that they're essentially getting larger and beginning to come together. The urogenital folds have sealed up. So those urogenital folds have sealed up. There's the perineum, and then there's the anus back here. But we're more focused up here. Just notice that the labioscrotal swellings have really swollen up, and then they're getting closer to one another, and that urogenital fold has really come together, and that's going to make the urethra, and you can see it going off here into the genital tubercle, which is becoming the penis. There's still at this point a urogenital sinus, and so there's no proper urethra, or at least not a penile urethra. It's just an opening at this point. So let's follow this along a little further. What's going to happen now is that the penis is going to begin to develop. A proper glans penis will be seen, and you can see that the scrotum has swollen so much, those labioscrotal swellings have swollen so much, they've become what we would call the scrotum, and they're joined down the middle. And in fact, that line of fusion between the left and right labioscrotal swellings is going to persist later on in life. And you can see it as something called the midline raphe. It's pretty obvious when we look at a newborn, particularly, you can see that scrotum here, and then there's the midline raphe that's joining it. And so that's where the labioscrotal swellings have fused. The other thing to notice is that urethra has sealed off, and so those urethral folds sealed off, and they're emptying now into the glans penis, and typically it's going to empty then at the tip of the glans, though we have developmental differences. Sometimes it opens at the base of the penis, and that's called hypospadias, and that can be actually surgically repaired. So this is a developmental plan. I moved through that a little bit quickly. So we started with labioscrotal swellings in a genital tubercle, and then it became larger labioscrotal swellings, and the genital tubercle began to extend outwards here at the beginnings of the penis, until finally we end up with the overall normal pattern of development for the XY, where we've got a penis and a glans and a scrotum. By the way, at this point, there would not be any testicles in that scrotum, because that's not going to happen till much later in development, probably not for another, 20 weeks, a long time yet. In females, it's really quite straightforward and a much more straightforward developmental pattern. What we'll see is the labioscrotal swellings here and here don't fuse, and they make the labia majora. So they make these fleshy extensions that we call the labia majora. The urogenital folds, here are the urogenital folds. Well, they don't fuse, and so they stay on as the labia minora. And in between the two labia minora is an area we call the vestibule. And I bring that up because there is our urethra. Because those two labioscrotal, where those two urogenital folds didn't fuse, then the urethra opens at the point that it opened very early in development at about 5 weeks. And so there's a relatively short urethra, right? The male urethra is going to continue all the way through the penis, whereas in this developmental pattern, the XX pattern, we're going to end up with the urethral opening right here at the vestibule. Now, the swelling that became the male glans penis becomes the clitoris in the female, and you can see it right here. So all of those structures, genital tubercle, labioscrotal swellings, and urogenital folds are going to develop in different patterns depending on the presence or absence of androgens. So if there are no androgens around, then we're going to tend to get this pattern with labia majora and minora and a clitoris, rather than when there are androgens around, where you're going to get the scrotum, penis, and glans penis. So that brings us to a discussion about intersex, which I'm sure you were wondering when we'd actually get to that. Sometimes it's referred to as disorders of sexual development, or DSD. I think that it's a little bit odd to call it a disorder of sexual development. I mean, it's a different type of sexual development. I kind of prefer intersex as a term, but really it's up to whomever this affects to make a decision about what they want to call it. At any rate, the definition clinically is when the baby's born, they have some male and female sexual characteristics and organs. And so at birth, an unambiguous assignment of male or female cannot be made. And that's the developmental challenge that people have to sort of think about what happened during development to have a sexual differentiation that's not clearly male or female. Now, about 1 to 2 per thousand newborns end up with some sort of surgery to correct ambiguous genitalia. And I say correct because their genitalia is essentially what it is. I mean, it's not wrong. It's just that's the output from their genetic and hormonal development. So it used to be that there was a very early so-called correction of what ought to be. So if someone was born and they had something that looked somewhat more like a penis than a clitoris, then they would decide, okay, well, that's going to be a boy baby. And if they had a penis that looked more like a clitoris, then they would nip it off to some degree and then say, okay, that's going to be a girl baby. But of course, that's not very wise, because there's a whole lot more to sex and sexual development than simply genitalia. About maybe 4 in 100 newborns fulfill the broadest definition of intersex. And so what that means is that the baby's born, and people often want to know almost right away, is it a boy or is it a girl? And you'll see that, for example, a baby boy with bilateral undescended testicles, it might not be that easy to say, is that phenotypically a boy or phenotypically a girl. And so there's also things like micropenis. So perhaps they have 2 testicles, but the penis looks a little bit more like a clitoris than a penis. And so that will make it unclear whether we can call them boy or girl. So it's fairly common if you take a broad definition, but fairly uncommon if you think about surgical interventions. Traditional synonyms for intersex have included words like hermaphroditic or are gynandromorphic. Hermaphroditic is sort of nice, especially if you like, the Greek literature. Gynandromorphic is marvelous. I love that word because gynos is female, andros is male, and morphos is body. So it's a male-female body. If it wasn't so darn hard to say, it would be a great term because I like it, in fact, better than intersex. So maybe we'll start up a movement. So we'll call people gynandromorphs, or maybe that's what they would like to call themselves. As a general rule, there's very few gonadal intersexes, and that's what we would call true hermaphrodites, and that means that they have both male and female gonads, which is to say they have a testicle on one side and an ovary on the other side. What's even more uncommon would be to have a functional testicle on one side that's making sperm and a functional ovary on the other side that's making eggs. Has that happened? Yes, it happens. I think just about everything you can imagine has happened for development, so it's possible. The greatest number of intersex simply have what we would say is ambiguous genitalia. It's not clearly male, not clearly female, and that's what you'll see occurring fairly commonly. So let's have a look at what we would call XX intersex. Not only does it rhyme, it's pretty interesting. So what that means is that they have two X chromosomes, so chromosomally they're female, but the external genitalia are going to appear to be male. And so this is intersex, of course, because you've got a little bit of disagreement between the chromosomes and the appearance. So typically, this is because of virilization of the female fetus by what we would call male hormones or androgens. And as you may recall, all the development of the external genitalia was driven by testosterone and epitestosterone. And so those are going to cause an XX fetus to develop in the male pattern. This is an example. We can see here that we've got XX. Well, you can't tell that it's XX, but in fact it is. So what we have here is a fusion then of the labia majora. Normally, of course, we would have a gap here. You can see that what's happened is we've fused the labia majora, and the clitoris, which is normally quite tiny in baby girls, here is quite large. And so that's what we would call clitoromegaly, which just means a large clitoris. And so when that baby is born, they may look and say, well, is that bilateral undescended testes with a micropenis, or is it fused labia majora with clitoromegaly? And the reason that they said fused labia majora and clitoromegaly is because they would have done the chromosome test and they would know that it was X. This person was XX. So how does that occur? Well, the testosterone usually arises because of an overactive adrenal gland in fetal development. You may remember that the adrenal is very active in making corticosteroids, but in that pathway they do make androgens. And so if there happens to be a very overactive adrenal, then you're going to have lots of androgens and you may end up with this. And because it's a disease that's caused by the adrenal, is called congenital adrenal hyperplasia. So congenital means you're born with it. Adrenal means it's from the adrenal or suprarenal glands. And hyperplasia just means that it's grown too much. And so we call this CAH. And that's a typical cause of XX intersex. And so as adults, this person is going to look similar to this. This person is 46 chromosomes, so that's normal, XX. And so they've got a genetic female, and they're going to have the sort of male pattern of hair, male pattern of development, musculature. I even think I see some male pattern baldness, which is sort of interesting. Clearly they have facial hair. So this person is genetically at least a female, but in fact feels like a male and was raised as a male and is probably pretty comfortable with that designation because of the testosterone that's circulating in their system. This doesn't say anything about sexual preference. That's a very difficult thing to predict, in fact. We're just talking about their appearance. So let's look at the other possibility. It's XY intersex. So this means that they're chromosomally male, but their external genitalia appear to be female, or at least incompletely formed along the male pattern. And so here is an example of that. You can see it's very similar to XX intersex. In this case, because they're XY, we say this is a micropenis. They're crypt orchid. There's no testicles inside of that scrotum, and they have hypospadias. I mentioned that before, but remember, hypospadias meant that the urethra opened at the base of the penis because the urethral folds didn't fuse to make a urethra, and so there's this opening here at the base of the penis where the urine is going to come out. So XY intersex has many causes, but generally we think it's because there's an inadequate supply or an insensitivity to male hormones. So essentially what we're saying, they don't make the androgens, or they don't have receptors for the androgens. So it's like the androgens aren't there at all. And so the most common of these is going to be what we call androgen insensitivity syndrome, so AIS. And in AIS, there's simply poorly formed receptors, or an absence of receptors. And if you had a shortage of androgen and an XY phenotype and genotype, you would have the same issue. It doesn't really matter. So typically what we're going to see then is that they're not going to have the female internal organs because they would have made anti-Mullerian hormone. And so what they'll typically have is a very short blind-ended vagina, because the vagina is not really part of that Mullerian system, at least the bottom 2/3 isn't. And so this person will often present in their early adolescence, and they'll wonder why all their friends are having menstrual cycles and they're not. Or later on they'll say, they're infertile or whatever. And so it turns out that in fact the reason for that is that they don't have any female internal organs. And so this is a person who's clearly phenotypically female. You can see female fat pattern deposition, and you can also see that there appear to be labia majora, and actually there's some very small amounts actually of hair, which is common. Even in females, it's the androgens that typically lead to axillary hair, so in the armpits and also in the perineal region. At any rate, this person is phenotypically female clearly, but has the XY genetics. And so this person would be female, in fact be quite comfortable as a female, and would probably go through their whole life simply feeling that they were infertile. And so we can see then that there's numerous types of development that are driven by the hormones and the genetics that you're born with. And so we can sort of say to ourselves that we can imagine someone that has 2 X chromosomes, 2 ovaries, or ovaries at all, and then they have a feminine phenotype, whatever that means, right? I mean, that's a very difficult question. Certainly everybody has certain feminine and masculine characteristics. And then also this person would self-identify as female. So all their types of sex are kind of in alignment, right? And so they're on one side of this spectrum. And the other side, if we follow it all the way over, we could have people who are XY in their genotype. They have testes, so they're gonadal sex is male. They have a masculine phenotype, again, whatever that means. Perhaps it means that they're huge and strong and hairy and all that sort of thing. And they self-identify as male, and that's what would put them on another end of the developmental spectrum. But the truth is, and I think I've tried to show you in this lecture, that there's a tremendous range of what people are. And in fact, we're all somewhere on this range. There's going to be people who have XX ovaries, feminine phenotype, but identify as male. And there's going to be people who have some feminine phenotypic characteristics and have some masculine phenotypic characteristics. But the truth is, we're all somewhere in that range. And so, when I see this picture of hermaphroditus sleeping, I think, we're all on that continuum of sexual development. We're all in there somewhere, so we're all kind of like hermaphroditus. So hermaphroditus, sleep well. You're just like us.